Good morning, everyone. I'm Neil Love from Research to Practice, and welcome to What I Tell My Patients. As today we talk about the management of acute myeloid leukemia, myelodysplastic syndromes, and myelofibrosis. We're really excited. We have a great faculty today, including one person who's coming in virtually, Dr. Ruben Mesa, who today is in South Carolina. How you doing there, Ruben?
Doing well. Glad to be there, Neil.
All right, well, hopefully your internet in the hotel is going to hang in there for a while. Let's just talk a little bit about what we're going to be doing here this morning. This is the 9th of 10 programs we've done here at the ONS meeting. This is actually our 15th year coming to the ONS meeting, and this has really been a great week for us. Here are the themes that we get into in this series. Number one, this is really a clinical research update for you, so that you can help your patients understand what's going on in terms of new developments in oncology, and particularly when they're receiving newly approved or newly available therapies. So hopefully you'll be able to explain more about sort of what's behind that. In addition to that, we're going to talk quite a bit about patient education. We ask our nurse practitioners on the faculty to present cases from their practices. Actually, Eileen and Rich work together, so some of their cases they take care of together. We'll ask them about what was it like to take care of this patient compared to another patient in the same oncology situation, but a different person. We also talk about sort of going beyond the therapies we give into the relationship that we have and the bond that we have with these patients and how much it means to them. And finally, really to turn around and say to you, people really value what you do as an oncology nurse. And great job, because patients and their families really appreciate it. So with that, I want to introduce the faculty. We have a tradition that kind of as a message to people new to the field that, you know, it is a challenging field to be in, an exciting one, but challenging. And we feel that really it's important to also get away from your job. So we like to start out by just asking people what they do to get away from their work. I'll start out with you, Rich Stone.
Well, I've born and bred in Boston, so I'm going to make some of you uncomfortable by saying I'm a huge Patriots, Red Sox, Celtics, and Bruins fan. And right now I'm all keyed up because two of our teams are in the playoffs, one of whom had a little trouble last night and has to win on Sunday to advance, even though the Bruins had the best record in NHL this year. So, yeah, I'm a couch potato, love Boston sports, and my claim to fame is I was in the 1975 World Series Game 6 where Carlton Fisk hit the home run over the wall.
Wow, awesome. So Dan Pollyea, what do you do for fun?
Well, I live in Denver at 5,280 feet, and I really like growing tomatoes, which is very difficult at altitude. And so what I like to do in my spare time, especially this time of year, is get my tomato seeds going and, just plan for the always short but fun tomato growing season in Denver.
Wow, that's a good one. Haven't heard that before. Sarah Tinsley-Vance?
Very, very nice. I like gardening a lot. I live in Tampa, Florida, work in Tampa, Florida, but live in Dover, which is very agriculture, and so a very agricultural area. So I garden, but I do like to go skiing once a year. So it's a lot of fun.
Ilene Galinsky?
So I love to travel. COVID kind of put a kibosh on that. So I'm really excited. I'm going to be going to Spain soon for 2 weeks. I'm looking forward to that. And as I've gotten older, I've expanded my horizons. I've trying to become a foodie. And I enjoy exercising and just being out in the outdoors. And one thing at work, I'm trying, my patients always tell me that not to sweat the big stuff, and so I'm learning to stop more and smell the roses.
Absolutely. And Ruben, when we planned this meeting, I thought you were in San Antonio, and now you just moved, but we're back here in San Antonio, you're over there. I guess you're in a hotel today for a conference. So what do you do for fun, Ruben?
Well, I love cycling and golf, and I see that you have a beautiful day in San Antonio. It's a great city, so hopefully the folks who are there for ONS will have a chance to explore a bit of that great and historical city. But yeah, over here in the Carolinas, we're get to explore a new place, another beautiful spot. Have a meeting today, but then heading off to the mountains in Asheville.
Awesome. Yeah, that's a great area. I've been up there quite a few times myself. Okay, here's where we're heading. We're going to start out talking about MPNs and myelofibrosis. Then we'll talk about MDS, and we'll finish out talking about AML. We're going to start out in a minute with a patient of Eileen's and Rich's, an 87-year-old man with MPL mutation positive myelofibrosis. But before we begin, Ruben, can you kind of just paint a little bit of a picture of what MPNs are, what myelofibrosis is, and what you typically see when a patient presents with myelofibrosis?
Wonderful, Neil. Well, I think it's a key part of today's session because it's really a type of a chronic leukemia. Although the term is related to the scarring that occurs in the bone marrow, you really need to think about this as existing in the spectrum with MDS and AML in the whole family of myeloid diseases. And again, was only named myelofibrosis in the 1800s before they really understood that it's a disease where there's a chronic leukemia, and then the consequence is a bone marrow that doesn't function well. So you have underproduction of red blood cells. There can be anemia. The white blood cells can be out of whack. There can be a drop in the platelets. There is scarring in the bone marrow. Now, what is a bit unique about this chronic leukemia is one that can have very difficult spectrum of symptoms: night sweats, fevers, chills, weight loss, a range of things that we think are associated with inflammatory cytokines, as well as sometimes dramatic splenomegaly. The spleen normally being about 300 cubic centimeters, it sometimes can be, 5 to 10 times that size and cause tremendous pain, early satiety, and other difficulties. So it's a chronic disease, and it's also in this session because it clearly can progress into acute leukemia. And when it does, it tends to be really quite refractory.
So we're going to hear about a patient, again, of Eileen's and Rich's, an 87-year-old man. But just to reflect back on the use of JAK inhibitors, and the first one was Ruxolitinib. Today we're going to talk about several others that have now, this has been a theme that we've been talking about all week. Often you'll see one agent and then more agents in the same class come along. Sometimes these newer agents, we were talking about, for example, BTK inhibitors yesterday in CLL, maybe they don't have more efficacy but different tolerability profile. And we'll see how this plays out on myelofibrosis. But just one more thing before we get to the case, Ruben, maybe just to reflect back on when the Ruxolitinib really came into practice. There were these so-called COMFORT studies, phase 3 trials. I think they were presented 10 years or so ago, and I know we all remember that. It was one of the most dramatic moments, really, in the history of oncology, because docs, the investigators, have been seeing this in the trials for a couple years, these incredible, very quick, symptomatic responses that people are having to therapy. Ruben, can you just kind of reflect back on that moment when we first started to realize that we were really going to be able to impact these patients and what we were seeing as they got Ruxolitinib clinically?
Sure. So just to set the stage, for the first half of my career, before there had been the discovery of the JAK2 mutation, or we had therapies like Ruxolitinib, we had tried many different drugs with trials, whether when I was at Mayo Clinic or our colleagues here at Colorado or at Dana-Farber. And to the large part, those studies really didn't work. There were drugs trying to aim to improve fibrosis or anemia, and they really were not very effective. So when Ruxolitinib, which was the first of the JAK inhibitors, was tested, even when we tested the first patients on the phase 1 clinical trial, it was clear that there was a dramatic difference over what we had experienced before. Patients could have significant decrease in the size of their spleen, and they could feel quite a bit better in a really rapid amount of time. So this was really quite a dramatic change from where we had been. That benefit was then really proven in phase 3 studies. two studies that led to the approval. Comfort 1, that was Ruxolitinib versus placebo, that was run in the US. And I and many of our colleagues were involved with that, leading that study. And then Comfort 2 in Europe, where they compared Ruxolitinib to whatever drug their physicians had chosen, many of which went on hydroxyurea. Indeed, we reflect back on that era, and there was a lot of use of hydroxyurea, which really was not a very effective therapy for the disease. Both of those showed significant benefit of improvement in spleen and symptoms. Over the years, the Ruxolitinib has been approved. It's also fairly clear that the drug has an impact on survival. Now, it does not cure the disease, but as someone who's treated many of these patients, it really can impact survival. And that's been validated both in the long-term follow-up from these patients, but also real-world evidence. Why do they live longer? I think they probably progress to acute leukemia at a lower rate. I think that is one factor. They're less debilitated, so there's less death through comorbidities, hospitalizations, and all the other difficulties that the disease can face. Indeed, I put a patient on the original Comfort study back in 2010, and just came off of Ruxolitinib, last January, after having had some progression, 13 years later. Now this is an individual who, when they went on the study, had a expected life expectancy of under 3 years. And this was 13 years later. So that's obviously kind of a best case scenario, but the impact really has been very, very significant.
All right, well, we're going to take a look at how this is now playing out many years after the introduction of this strategy, the introduction of new agents, and how, it's never as simple as it sort of seems on paper in the guidelines. So let's jump into the cases or see how it really plays out in practice. And Ilene, you have an 87-year-old man with a past history of benign pleural effusions, pericardial effusions, MPL mutation positive myelofibrosis, who gets Ruxolitinib. Can you talk a little bit about this patient and sort of what his situation was when you started the Ruxolitinib?
So he was an active gentleman. At the time, it was several years ago when we met him. He is still active to this day. He was kind of a gentleman that he beat to his own drum. So he was kind of going to do his own thing anyway. His biggest thing was his fatigue, which is a side effect of myelofibrosis. Maybe at the time you would say, why are you treating someone for a symptom of fatigue? But it can really impact someone's life. So we started him on Ruxolitinib, and he had a significant decrease in his fatigue. He was able to work more. So he felt very comfortable on the therapy. We were monitoring his drugs, and he's done well. He has a lot of other medical issues, and now he's having symptoms which we think are probably from the Ruxolitinib, of fevers, etc., that we're trying to deal with him.
So, Rich, can you further paint a little bit picture of this patient? You were telling me, Ilene says, quote, he beats his own drum. Can you elaborate?
Sure. Well, it's probably medically and psychosocially relevant that he does not believe in vaccines, and he was taking Ruxolitinib, which is immunosuppressive. During the period of COVID, he was pretty lucky. Until recently, as Ilene mentioned, he's now having problems with fevers and pneumonias and infections, but he didn't for many years. He works, runs his own company, goes to work every single day, and values that above everything else. And as you know, we're not treating just numbers in a clinical trial, we're treating human beings. And as you know, we have to pay attention to the type of people they are. So he wanted to maintain his active lifestyle as much as he could. He's very close with his supportive wife. And he was very happy on Ruxolitinib. It allowed him to do what he wanted, which was work, mainly, and be with his family. And so it was a success story. I learned not to ask him about getting vaccinated for anything, because he would just cut me off immediately. And I'm sure that depending on where you come from in the country, you understand that one has to be careful about those issues nowadays with our divided country.
So, Dan, I'm curious about your experience with ruxolitinib. This patient's a little atypical in that he didn't have a big spleen, he didn't have spleen symptoms. In the patients, and you see pictures, I think we have some in the slides, you can even see the spleen sometimes in these patients. What's been your experience in terms of the typical response in terms of symptoms?
Yeah, I think this is typical and atypical. I mean, not having the big spleen being the biggest concern clinically is, maybe not the most common reason for starting ruxolitinib, and one of the main endpoints on those studies was, shrinkage of the spleen. But we know that these patients can be horribly fatigued by this sort of cytokine-mediated process and can really respond beautifully to ruxolitinib with respect to that symptom. The other thing I want to point out is that this is a bit of an unusual situation in general in our field in myeloid malignancies, because as you notice, ruxolitinib is we call it a JAK2 inhibitor, and this is a patient who doesn't have the JAK2 mutation. So I think it's really important to point out that unlike other aspects in our field where you have to have the mutation to get benefit from the targeted therapy, this is not one of those situations. So this is a JAK2 negative patient still deriving benefit from a JAK2 inhibitor, and so just make sure you keep that in mind. When prescribing this, that is not a requirement for this treatment.
Yeah, that's a great point. Last night we did a program on non-small cell lung cancer, and there they have all these somatic mutations. They target him. Ruben, this patient had MPL mutation positive. Can you and we've talked a lot about biomarkers in general in oncology and how important they become, although as Dan said, this is an interesting situation because a JAK inhibitor, ruxolitinib, actually works whether you have a JAK mutation or not. Ruben, what kinds of mutations do you see in these patients, and why is it that these JAK inhibitors work even in patients that don't have JAK mutations?
Well, it's a very good question. So first, there's three main mutations that are associated with myelofibrosis and also with polycythemia vera and essential thrombocythemia, earlier disease. The JAK2 V617F, that's a specific point mutation in JAK2, and that's present in about half of the patients. There is MPL, that's probably the least frequent of the three, the one where there is for this patient, and that's involved with the thrombopoietin receptor. And then there is calreticulin, which is present in about a third of patients. Now, the medicines are inhibitors of JAK2, of the native JAK2. It is not specific for the mutated form of JAK2. So that does make it quite a bit different than, let's say, imatinib, which is an inhibitor of a protein that otherwise is not present in normal life, BCR-ABL as a fusion protein. Now, why we have found over time the JAK inhibitors are helpful regardless of the driver mutation is because all three of the mutations are overactivating the JAK-STAT pathway. So they're activating JAK2 all in a different way, but they still all overactivate JAK2. And it's felt largely, even in individuals, there's a smaller subset of individuals that lack any of these three mutations that have been referred to as triple negative. Now, I always say that with a bit of cringe when I have colleagues in the audience that also see patients with breast cancer, because clearly that's their term that is not my fault, but that we shamelessly lifted from the breast cancer lexicon. But even those patients, everyone has the JAK-STAT pathway turned on. These drugs really help to stop the JAK-STAT pathway, and that is why they really help to lead to a similar benefit irrespective of the mutation status.
And I'm going to turn to Rich in a second to talk a little bit more about what cytokines are and whether maybe even in this patient why the fatigue might have gotten better. But first, I want to get to Sara and ask you, when you are starting a patient on Ruxolitinib, for example, for myelofibrosis, what are some of the things you think about when you're sitting down with them that you want to get across in the initial meeting when you start talking about this?
That's a very good question. I want to make sure they understand their disease and what we're trying to accomplish. And I also want to get to know the patient, see what's important to them, and see what their support system is, see how far away they live, and the ability to be monitored on a regular basis. And then we discuss the drug and how it fits into their life with their values, goals, and preferences, and then talk about what we're trying to accomplish by treating them. So with the Ruxolitinib, as you all pointed out, we're really trying to, if they have a very enlarged spleen, we're trying to reduce that spleen, but also we have a beautiful tool for measuring symptoms in our myelofibrosis patients and other myeloproliferative neoplasms, the total symptom score. So if we can, we like to do that, administer that and see how many of the symptoms they have. And then also, is that distressing them, and see if we can get a reduction in those symptoms as we treat them, and we talk about that. And then make sure that we keep them safe, look at their liver function tests, look at their CBC as they're on therapy, because since it does work on the bone marrow, you get a reduction in those blood counts initially. And so we talk through that, and we make sure that they can commit to having their blood monitored regularly.
One of the things we've been talking about all week is, okay, we know in general what we want to try to communicate, but now what's the best way to work with this individual patient? And again, you're already getting the message. This is not maybe the typical patient. So in a second, I'm going to ask Ilene what it was like to talk with this man about patient education. But first, Rich, to get back to this idea of the fact that in general you see activation of the JAK-STAT pathway, and these drugs are trying to tone this thing down. You were telling me that you thought maybe the fact that this man's having an improvement in his fatigue may be related to the Ruxolitinib and maybe a cytokine effect. Can you kind of explain what cytokines are and what kind of symptoms you see?
Sure. Well, cytokines are part of the basic biology of inflammation. It's what we learned the first week in medical school about how important inflammation is as a basic response to stress. It comes from our ability to need to fight infection. And as Ruben mentioned, these things inhibit the JAK-STAT pathway, which is a basic pathway by which cells respond to inflammatory signals and generate these proteins, by and large, they're proteins, which mediate the inflammation. So it's sort of a disordered response to a stress signal. Cytokines are so important in biology, both in basic biology and in things like why people on CAR T cell therapy get sick. I often tell the house staff, if you don't know the answer, say cytokines. It's kind of like saying, if you don't know the answer to a math test, you write 0 or 1, usually you're right. So it's like if you don't know the answer to a question that some idiot attending old guy says to you, say cytokines. So we're interrupting the cytokines, which can make people sick. But remember, if you look on TV and you see all those ads for psoriasis therapy or asthma therapy or inflammatory bowel disease therapy, those writ large are also anti-cytokine drugs, and every one of them, the guy says in a low voice, this could cause fatal infections. And that's because you're playing with a little bit of fire when you interrupt the cytokine pathway. So it can both be good to interrupt it by making people feel better if the cytokines make them feel crappy, but it can also be a little dangerous. And I have seen some really serious infections, including hepatitis B, and COVID in people who've been on JAK2 inhibitors.
Yeah, and actually part of COVID pathophysiology, Dan, I think also is related to cytokines. What kind of, the theme of, susceptibility to infections we were talking about yesterday in our CLL program, what kinds of infections do you see in patients with myelofibrosis? We'll talk about this with acute leukemia, et cetera. This man apparently now is having some infectious issues. What kinds of infections do you see, Dan? And what do you do in terms of prophylaxis?
Yeah, great question. So I think it can run the gamut. I think, these patients often, due to their disease, are neutropenic. And so, neutropenic precautions and neutropenic susceptibilities are in play here. And, usually or often that's bacterial infections, or if this goes on long enough, fungal infections. Suppress the immune system further than what the disease is already doing with one of these therapies that inhibits cytokines. And I think anything is in play for the potential for infectious complications. But, I think they are more susceptible to viral infections at that point. And I think that's something that we really need to be aware of.
So Eileen, I'm curious, when you first met this man and you started talking about Ruxolitinib, what was it like to interact with him as a patient? Actually yesterday we had a patient presented in our program of diffuse large B-cell lymphoma who was a Jehovah's Witness with recurrent diffuse large B-cell and wouldn't refuse to consider CAR T, potentially curative therapy. So it gets into the theme of trying to line up with your patient's value system, as Sara was just talking about. What's it been like to work with him? What's it been like to sort of teach him?
So at first, I obviously have known how he has been in the past with his thought process. Him and his wife can be very difficult. Obviously, I tried to go in with a clean slate on my head and try and know where they are and try and work with that. At the same time, they're on a medicine that I have to make sure they're going to take and follow our rules. And so the key things are, as Sara mentioned, myelosuppression. So are they going to get their blood drawn when I tell them to every week? They wanted to get their blood drawn locally, which is a big pet peeve of mine because I got to track them down and then try and figure it out. But we worked that out. Also talking to them about side effects. And thirdly, because he didn't like to come into Boston, to stress the importance of wherever you go, if you get admitted or anything, to always bring your Ruxolitinib with you because you cannot abruptly stop Ruxolitinib. It has to be tapered. So tried to stress that, and at each visit, they became more, and being that he responded, I think that helped a lot, that his fatigue got better. So then he began to trust what I was saying, and then he saw the benefit of if he followed through. So that was our happy median.
So we're going to go on in a second and talk about some of the newer JAK inhibitors that have come along with slightly different profiles than Ruxolitinib that create advantages for it. But just to stop for a second based on this case and come back to Ruben and ask if you have any thoughts about the case as you've heard it. And maybe you can talk a little bit about what happens typically to patients who are on Ruxolitinib, and particularly how you deal with it when and if they start to develop progression of disease.
Sure. So your average patient on Ruxolitinib with myelofibrosis, receives the drug anywhere from 3 years plus, but probably 3 to 4 years is probably the average. You could think that the outcome kind of falls into several different buckets. One bucket is individuals who don't respond, and that's actually quite uncommon. There's probably more people fall into the second bucket. They have some response, but you think that there's an opportunity, you would have wanted a better response, more reduction in the spleen, more improvement in the symptoms. Again, even like this case, we do think that overall patients, many of them are better off being on a JAK inhibitor than not being, than being on nothing. It helps probably, again, in terms of inflammation, cytokines, but also probably in terms of the disease course. I tend to look at the reduction in the spleen, not as the goal in and of itself, although it clearly has benefit in terms of symptoms, but it's really a marker of the response. We saw from the comfort studies that even a greater than 10% reduction in the volume of the spleen was associated with improvement in survival. I don't think that's because of a mechanical decrease in the size of the spleen. I think it's really because there's a benefit to the JAK inhibitor response, and the spleen is just a very helpful kind of overt, manifestation of that. Now, over time, I think folks fall into several buckets. One is that because of the limiter of ruxolitinib is that it does not improve cytopenias, and in some folks it can worsen cytopenias, and that's probably more common, although usually it's not a limiter. But when it is, it leads to really underdosing of ruxolitinib. So in the US, I'd say that there's a lot of patients out there on subtherapeutic doses of 5 milligrams twice a day or something of that nature that we believe is just not associated with an optimal response. So one, there's kind of that group. They haven't responded well enough. They're on too low a dose to really have a benefit. Two, they clearly can progress. And they could progress really in one of two ways. One, they can progress with further enlargement of the spleen, symptoms, debilitation. Or two, they progress towards acute leukemia, increasing blasts, worsening cytopenias, both problematic, both different. I think the former were progressive splenomegaly, symptoms, inadequate response, cytopenias. That's where I think this module 2 really falls into play. And then the other group really is in that module 4 and 5 that we'll discuss later. As they progress toward acute leukemia, they tend to fall in that category of very high risk acute leukemia, tend to have a lot of mutations, tend to be more refractory.
Let's talk about some of the newer JAK inhibitors. There are 3 that we want to talk about: Fedratinib, Momelotinib, and Pacritinib. And in a second, we're going to hear about Sara's pretty interesting, unusual patient who got Fedratinib. But Rich, I know you were involved in the earlier development. Can you talk a little bit about what Fedratinib is, and just very briefly about sort of the interesting history that it's taken to get here, so to speak?
Sure. As Ruben mentioned, when the field broke open, when it was recognized that JAK2 V617F mutations were a key driver, and that the other 2 driver mutations, CALR and MPL, also activated JAK-STAT, as Ruben mentioned, and led to some of the pathophysiological and clinical problems we saw. Before I answer your question, I just want to digress and give a quick shout out to Ruben in this audience of nurses to say that symptoms, in contradistinction to many other cancers, are number 1, 2, and 3 in this disease. And Dr. Mesa developed a tool which we can all use, I forget what it's exactly called, the Myelofibrosis Symptom Score, I think, which you can actually objectively characterize symptoms and then determine if the patient's benefited from therapy A or B. So that's hugely important. It impacts what we do on a daily basis. So Ruben, great work. And you made a lot of money for the drug companies, but more importantly, you helped patients a great deal, and everybody in the audience probably uses that. And so in an effort to develop other drugs that would help, a drug company came along and developed this drug called Fedratinib, which was frankly pretty similar to Ruxolitinib, but it was hoped that it would either be better than Ruxolitinib and used in the upfront situation, or would work when one of the patients was in the bucket that Ruben just talked about, where they failed Ruxolitinib. And there were 2 trials, Jakarta 1 and Jakarta 2, that showed that it was useful in the upfront setting compared to placebo, and Jakarta 2, where it showed that it had activity in the Ruxolitinib failed setting. So it was really initially developed as a second-line agent, or a first-line agent, but realistically second-line. What Dr. Love was talking about was that the initial development was halted for a while because there were patients getting Wernicke's encephalopathy, which probably we don't see very much, but it's a thiamine deficiency that can be associated with significant mental status decline, and drug was halted. What was really interesting was that when the data was parsed carefully, very few, if any, of the patients really had Wernicke's encephalopathy, and very, very few of them get anything like that if you maintain their thiamine levels at a reasonable level. So another drug company purchased it briefly, sold it to a third drug company, a big drug company, and then it was actually, the data was resurrected from the original drug company, and it became an active agent. So I'll be interested in Dan's and Ruben's thoughts on this. I don't use it that much. I do use it in situations where the patient still fails Ruxolitinib, but needs a JAK inhibitor therapy because their spleen is big. I rarely use it in the upfront situation.
So let's hear about this patient. You know, it's interesting when we're talking about this patient in the faculty room, everybody says, whoa, you never heard a case like this. So it's sort of theoretical. You hear about thiamine deficiency. I don't know, we'll ask Ruben if he's ever seen a case like this. But what happened with this 75-year-old man, Sara?
Well, he's a close friend, because I saw him so frequently when he was first diagnosed, then saw him on Rux, and then when his spleen was growing bigger and he needed another therapy, he got Fedratinib second line. So we did our due diligence, we know about the drug, and we checked his thiamine level, which was therapeutic, and then he was having a response, some reduction in his spleen.
He was responding.
He was responding. Huh. But he got confused and we ended up admitting him, and his thiamine level had gotten low on the drug. So that was very upsetting to him because he's very active. And I think it was memorable for me because it was my first experience with a second line treatment for myelofibrosis patients after Rux, other than a clinical trial. So it left a lasting impression. You know, check their thiamine levels while they're on treatment.
So how's he doing now? You put him on thiamine. How's he doing?
Yeah, unfortunately, he passed.
So he progressed.
His disease took him. He developed progressive thrombocytopenia, had a fall, and had an intracranial bleed.
Interesting. So. Ruben, have you ever seen a case like that?
So from the initial studies from Jakarta, there was one of the patients that we'd had that had this suspected Wernicke's encephalopathy. You know, after the drug's approval, you know, thiamine, of course, is just vitamin B1. It's very inexpensive. You know, although it's not in the label, you know, I put every patient who I treat with Fedratinib both on some GI prophylaxis, you know, because much more common than this is it can have some GI side effects. That's probably its main difference in terms of toxicity profile with Rux. But clearly this is an issue. Now, it's a rare issue, but I put everyone on thiamine up front to really try to prevent it to the best degree that we can. You know, there have been currently ongoing studies called the Freedom study, which have been post-approval studies, you know, where we're monitoring thiamine as well as kind of the intervention of check the level, replace if need be, what have you. It clearly can decrease it in some. So I do think that is you know, worth a word of caution. I think when we looked at the cases, I was the one writing up, along with Claire Harrison and others, the cases from the prior studies on the Wernicke's encephalopathy. It was clear that the patients all trended toward that risk, were older, or had GI side effects, or had nutrition issues. You know, so it didn't occur in a vacuum. You know, wouldn't expect it to be in young patients. It is a helpful drug. You know, I would say that it's a drug that currently is underutilized. You know, for individuals with Rux who have failed Ruxolitinib, who have a big spleen symptoms, it's a very active drug. It is probably less helpful in those with really low counts that overlap then with Momelotinib or Pacritinib, but it probably is an underutilized drug at this point.
Yeah, really interesting. In fact, that this patient responded after having progressed on Ruxolitinib. Ruben was talking about the Jakarta studies. We put some of that in your slides for you to check out. But clearly, you know, we've been talking about waterfall plots, and you know what we've been saying, that each one of these sort of lines is a patient, and if it's going down, this is a spleen size. So if it's going down, it means the spleen's decreasing in size. If it's going up, and if you look over on the right, most of these patients, the spleen is continuing to grow in placebo. But on the left, you see almost all the patients, the spleen volume is decreasing. Here's the Jakarta 2 study as well. Same type of thing you see on the waterfall plot. So let's talk a little bit about these other JAK inhibitors and where they fit in. It sounds like Fedratinib has a useful role, but we have to maybe keep in mind to try to replace thiamine. Ilene, how about your 83-year-old woman, multiple comorbidities, who got Pacritinib?
So this was an interesting woman. When she came to us, she had a performance status of about 3. The platelets were in the 10 to 12,000 range. She had an enlarged spleen, but she had a lot of comorbidities, and at that time, she didn't want to do anything, and I don't think we felt we could safely give her anything except supportive care and give her transfusions. She ended up improving in her status, and she had a really supportive husband, so we gave her and started her on low-dose Pacritinib because of her platelets being low. She tolerated that very well. Her spleen shrunk. She was having early satiety. She doesn't have that anymore. Her energy level has improved, and she's tolerated it very well. Unfortunately, now over the last month or so, some of her comorbidities are rearing its head again, and we actually just admitted her last night with a fever, but she was told she actually brought her Pacritinib with her to the hospital, so we can still continue to give her that therapy, because just like Ruxolitinib, you can't just stop the Pacritinib.
So, Rich, a performance status of 3. This lady sounds like she was really sick when she got started on treatment, maybe even a question of should she go for palliative care. Can you talk a little bit about your thoughts when you first saw her?
Sure. Well, she's a more typical older adult with multiple comorbidities. She has had a history of PE, DVT. She also has chronic severe sputum production, thought possibly on the basis of allergic bronchopulmonary aspergillosis. And her son is a palliative care doctor across on the other coast from where we are, who occasionally calls in and has some advice like have her see palliative care, which makes sense. She's a very nice lady and has the interesting part about her situation is she's not straightforward. She has an MDS-MPN overlap syndrome and does not have a typical driver mutation, has an SRSF2 mutation, but her counts are interesting. She has a very high white count, runs around a white count of 30, borderline anemic, and as Ilene said, her major problem hematologically is thrombocytopenia. So she posed some problems. I finally threw up my hands and said, well, your spleen is bothering you, let's see it, and maybe some of your symptoms of profound fatigue, which is her complaint, as it is in so many patients with all the diseases we're talking about today. We tried Pacritinib, but it did, as Ilene said, helped her, whether it's playing a role in her current possible infectious issues. It's hard to tell, but so on balance, it was sort of an end-stage hope. And it's the drug that, as Neil just put up, it's a drug you can use in the setting of thrombocytopenia. In fact, it's indicated it's approved in patients whose platelet count are less than 50.
Interesting that her son was a palliative care physician, because the picture you're painting, and I'm thinking palliative care, hospice probably was something you were thinking about, and yet it sounds like she benefited from therapy. Ruben, can you talk a little bit about the cytopenias that occur, both thrombocytopenia as in this patient, also anemia, which is very common with myelofibrosis, what the differences between Pacritinib and Ruxolitinib and how it's utilized?
Sure. So one, at disease baseline or at diagnosis, anemia is present in many of those with primary myelofibrosis, but probably much less so for individuals with post-PV myelofibrosis. So when we speak of myelofibrosis, it's 3 groups of patients, and when we speak of cytopenias, there's a little bit of a difference. Those with primary myelofibrosis, it's the first disease that they have been diagnosed with. They tend to have less of the JAK2 mutation. They tend to have more upfront cytopenias. And patients who progress from ET or PVERA, that tend to come into the diagnosis with higher counts because they're kind of transitioning from having way too high accounts. So they went from really needing phlebotomies to now sometimes having more normal hemoglobins to then potentially having anemia. But there are patients with post-PV myelofibrosis who will pass away even without ever having anemia. So they are a little bit different. Anemia is quite a bit more common than thrombocytopenia. Thrombocytopenia at baseline is probably in a minority, probably less than 20%, but both of these issues climb in difficulty as the disease evolves. And as it relates to inflammatory cytokines, hypersplenism, inadequate production in the bone marrow, and a range of difficulties. Now, Pacritinib, from the early days when we tested in the phase 1, it was clear did not lower the platelets in individuals even with baseline thrombocytopenia. Over time, research has helped to try to identify, well, why is that the case? And in terms of mechanism, with research done by several Stephen O and Alan List and others, it seems that work around the inflammasome may be some of the difference, that it is an IRAK1 inhibitor, it's an ACVR1 inhibitor, has a little different kinase inhibition of profile than Ruxolitinib does, and maybe, again, allowing it to be utilized in individuals at full dose with marked cytopenias. So the label for Pacritinib is quite distinct from the label for Ruxolitinib and Fedratinib. It's specifically labeled for individuals with a platelet count below 50,000, whether in the frontline or second line setting. It can be used at full dose. Now, the platelets may stay the same, they may increase, but the key is that patients really can be fully dosed. Whereas with the other agents, typically if it's been used, below 50,000, one that's lower than label, and two typically have been used at a markedly reduced dose. So I think the difference is that you can really use full dose to try to have the full benefit of JAK inhibition, in these individuals. So if it's in the frontline setting, you can use Pacritinib, and certainly in the second line setting in these patients as well. They overlap to some degree with patients with a platelet count between 50 and 100,000. There's good data from the PERSIST-2 study showing benefit for individuals with a platelet count below 100,000. I certainly will consider it in those individuals, both in the front line and in particular in the second line setting, if they have significant thrombocytopenia.
I like that idea of the inflammasome. I've never heard of that term, and I like this IRAK1. And usually, I don't understand these diagrams, but this is pretty cool in terms of maybe why they don't get, or why it doesn't affect the platelets. Let's talk about the other new entry to the field, Momelotinib. And Sara, you have a 79-year-old man who started out with polycythemia vera, as some of these patients do, and then progressed to myelofibrosis. Got Momelotinib. What happened with him? I'm assuming he was anemic.
Yes, he was anemic, receiving 2 units of red blood cells every 2 weeks. He's on clinical trial since this is not FDA approved yet, and he's having a beautiful response, a reduction in his transfusion requirements to the point that we're trying to get rid of some of that excess iron now. So we have to be careful with how that interplays with the Momelotinib.
Now, has this patient gotten Ruxolitinib in the past?
Oh, yes. He's been on 5 agents.
5 different agents.
He's been on multiple agents in clinical trial.
And he's clinically responding?
He is as far as his transfusions, but I would say he has the biggest spleen I've ever seen. It even tucks into his pelvis, and he developed a hernia that we had to get carefully repaired.
Interesting. So Ruben, I'm curious about your thoughts on also this issue of patients who post-Ruxolitinib are having splenomegaly, spleen symptoms. Do you ever use local therapy to the spleen, surgery, radiation therapy? And again, any comments about mechanism of action of Momelotinib and why you can give it to patients with anemia?
Sure. So perhaps starting with the non-medical approaches. In the past, we had used a range of things, particularly when our therapies were not effective. Splenectomy, localized radiation therapy, people had used splenic embolization. So first, splenectomy, it is a surgery we're doing less and less each day. There's a lot of risk. There's a lot of post-splenectomy risk of thrombosis or hemorrhage and delayed hemorrhage, as well as the blood count sometimes can really just go haywire, really high white count, really high platelet count, and sometimes can lead to catastrophic complications. Indeed, the patient I saw as a first-year medical student with then a hem-onc fellow Ayalu Teferi that got me interested in myelofibrosis was a poor woman from Venezuela who was 35, who came to Mayo Clinic, who had a spleen that was massive, had a splenectomy, bled out, and died. And as a first-year medical student, it was very traumatic. She had young kids; they were all there. They had come from Venezuela. Really very tragic. So these days we really use that, quite sparingly. And I do think that when it's done, you really need an excellent surgical team. They tend to need to bluntly dissect the spleen away from the abdominal wall. There's a lot of delayed hemorrhage. Really best to avoid it if you can. Radiation certainly has a transient but helpful benefit. It's so transient that, again, we don't use it to a great degree. It doesn't take a big dose. There have been times that stem cell transplanters have been using that a little bit in refractory cases post or pre-stem cell transplant to try to decrease the spleen to have some impact on engraftment. But overall, the local therapies aren't great. And embolization, as you might imagine, causes horrendous pain, and again, not overly effective. Now, Momelotinib, I'm hopeful will be approved later this year, perhaps even by June, and has, again, a real differentiator. It's probably the most active of the four as it relates to anemia. It, like Pacritinib, has a different kinase profile as well that can also improve ACVR1. We think that why that is beneficial is it decreases hepcidin. Hepcidin is associated with inflammation and anemia of chronic disease, and can lead to both improvement in anemia and transfusion independence, while still improving splenomegaly and symptoms. So we most recently presented data at ASCO and ASH regarding the Momentum study. It was Momelotinib versus danazol in individuals that had failed Ruxolitinib. Why danazol? Danazol probably is our most effective therapy that we have for individuals that have anemia in MF. And with this, we saw improvements in spleen that was clearly superior to controls, in symptoms that were better than controls, as you see here in this slide, and then also in terms of anemia. The planned analysis was a non-inferiority. It was clearly non-inferior. It was very close to being superior. So overall, as an overall therapy, much better than control, but also very helpful indeed. So I do think that with an approval, we likely will see, good utilization of Momelotinib for those patients with anemia.
So we're going to move on now, talk about myelodysplastic syndromes and AML. We'll keep Ruben here on the line, but there are very few people who have been involved with the research on myelofibrosis the way Ruben has, so it's really great to be able to work with him today. In a second, I want to hear about your 81-year-old man with MDS and anemia who actually got luspatercept, which is a relatively new development in the field. It's really had a very big impact. But before you do, Rich, can you kind of provide a global picture of what MDS is and how we categorize it based on low risk and high risk, and what the overall flow is of therapy in these patients?
Sure. I tell patients that they have MDS, but it's a very heterogeneous disease, which means that one patient's MDS can be vastly different from another patient's MDS. Because immediately when a patient learns they have a cancer diagnosis or anything in this field, they look at the internet and, of course, they get scared. So sometimes that fright is appropriate. Many times it's not as bad as they think. In fact, it's always less bad than people think. That's just human nature. So heterogeneous disease, which we say is a bone marrow stem cell disorder, one characterized by hypercellular marrows where there's too many cells in the marrow, and peripheral cytopenias or not enough cells in the blood. I call it famine in the land of plenty. There's lots of cells. I tell patients it's like a factory that's making cars, but all the workers are drunk. They're trying to put the cars together, but they end up with really lousy output on the other end of it. And obviously, we try to make things simple. We do talk about lower versus higher risk MDS. We can talk about how we make that determination. But to a very first approximation, higher risk MDS is like early AML you could think of, often has excess blasts. It's not that simple. And lower risk MDS is more like bone marrow failure, where largely anemia, but sometimes thrombocytopenia is the biggest clinical problem. And fatigue is a universal symptom in people with MDS, one that we have a lot of trouble fixing. And I want to just say that although many patients with MDS are anemic and almost all are fatigued, when you fix the anemia, you don't always fix the fatigue, and that may be due to cytokine release. So it is basically a bone marrow failure syndrome with either excess blasts or not, and it's very heterogeneous with prognosis ranging from 10 years down to 6 to 18 months. So you have to try to figure out where your patient fits on that spectrum.
Again, before we hear about this patient, Dan, I'm curious about your experience with low-risk MDS in patients with anemia requiring transfusion and how you've managed this in the past and where you see this heading, particularly in terms of the introduction of luspatercept. We know there's a trial out there comparing it to ESAs. We haven't seen the data, but apparently it's a positive trial, so maybe our approach to these patients is going to be changing over the next couple of years, maybe even a combination of luspatercept and an ESA. How are you approaching it right now, Dan?
Yeah, thanks, Neil. I mean, like so many other things in our world, our patients, it's highly personalized. As Rich nicely said, MDS is a disease on a spectrum. Patients at the lower risk end of that spectrum may still be quite symptomatic and impacted by this disease. Of course, there are some patients who need no treatment at all and can be observed for many years. That's great. When people move along that spectrum to where, for instance, they start to need transfusion support, that might be a trigger to determine, okay, this is a time when now we might want to think about a treatment. However, I just want to also say there's patients for whom, even when they move into the requirement of a transfusion, that's a great treatment for them. I mean, it's not a treatment, but that's a great strategy for them to receive occasional transfusions. Some people, they need a couple transfusions a year, maybe one every couple months, and they feel great. They have a good quality of life, and that's maybe one of the least harmful things we can do for the patients. So we should keep that in mind. But yes, I mean, I think when you go beyond that in terms of need, or interest in modifying the disease itself, that's when we sort of start to talk about treatment. Luspatercept, as you brought up, is a great new potential therapy for, right now, a subset of patients, those with this ring sideroblasts or an SF3B1 mutation. Those two things usually overlap, but in effect, patients in the lower risk end of the spectrum, we might be able to more broadly use luspatercept in other lower risk MDS subtypes. We're waiting to see if how that looks. But I think luspatercept is nice, and it's a nice potential way to boost the hemoglobin a bit. It's not, we're not really sure or convinced that it is in itself disease modifying, that it can actually change the natural course of the disease in the bone marrow. And so for that, I think we're going to need to look at other therapies.
So again, before we hear about the case, just coming back to Ruben, I know obviously anemia is an important issue in MPNs as well, and myelofibrosis. What do we know about luspatercept in that situation, Ruben?
Sure. So there clearly is overlap in terms of activity. We've had single agent studies as well as combination studies with luspatercept for patients with myelofibrosis. There currently is an ongoing phase 3 trial of which I'm involved with that is looking at this as incremental therapy to try to improve anemia. Clearly has been, one of the great limiters. And we both have patients both on trial, but certainly there have been MF patients that have received it off-label, depending upon insurance. Some of them have been more permissive than others of allowing it, particularly in refractory patients. And I think anemia is something that is both a tremendous burden for patients, and it's certainly something that helps to drive, physician practice as well. The need for transfusions is not to be underestimated. Clearly with this audience that is involved with the care of these patients, that when a patient needs a transfusion, it really is very disruptive in terms of their quality of life. They have to stop. They have to make time to get a type and cross. You need to find time in the infusion unit for them to be able to receive blood. During this whole last period of the pandemic, trying to have space. Is it safe to come in? Can they get 2 units today? Can they only get 1 unit today and 1 unit tomorrow? Do they need Lasix? If they get Lasix, are they up peeing all night? It's very difficult, and if you have to go through that whole song and dance, once a week or once every 2 weeks, you're very, very tethered to the medical system. You can't go for a month to go visit your grandkids in Florida because you got to worry about where you're going to get blood while you're there. Maybe you can go visit Eileen at Moffitt to get your blood if you're lucky enough to be in Tampa, but if you're in another spot, maybe not so. So very difficult. That's why I think great interest in trying to improve anemia. And I think luspatercept, clearly is an additional helpful drug in the mix.
So it's actually Sara in Tampa. But anyhow, Eileen, let's hear about this 81-year-old man who actually got luspatercept. What was going on at that point when you first started the luspatercept?
So he was severely transfusion dependent, and it was affecting, as Dr. Mesa said, like his quality of life coming in, getting transfused. He, as we've all said, fatigue, big part. And, he responded initially to the transfusions, but then that duration of feeling good stopped. So after getting insurance approval for luspatercept, because it is a costly drug, he received his 3 doses. You get it every 3 weeks, and you titrate up the dose if that's tolerated. And he responded incredibly well after the first dose, remarkably, and I'm not saying he's the norm, to the point that after the 3 doses, he didn't need any more, and he was able to travel, etc. He did not need transfusions at all. And then he came back to see us like 8 or 10 months later.
Wow.
And we saw a little decrease in his hematocrit, not enough. So we used the guide of his fatigue and the dropping of his counts to dose him again. So he's kind of on a Q6 to 9 month schedule of us giving him 1 dose of luspatercept. He responds and is able to carry on all his activities.
So, Rich, any comments about this patient, about anemia and MDS, about luspatercept, and also where this might be heading? We know that, again, there's a trial out there comparing it to ESAs that we'll be seeing that's being looked at in combination. Any comments, Rich?
Sure. So I think luspatercept it can be an amazing drug as it was for this patient. This patient is an MDS-MPN overlap. He has features of MPN. He has a JAK2 mutation and a relatively high white count, but he has an SF3B1 mutation, ring sideroblasts, and the anemia that Eileen mentioned. He's actually on hydroxyurea to try to decrease his risk of clotting, and he's also on medicines, as luspatercept would be the example, to try to make his hematocrit go up. But as Eileen mentioned, he got so good after he got a few doses of luspatercept that he was actually able to go to Tibet in the Himalayas. He was a mountainous country, went with his friend. Actually, when he was at the airport in Tibet, he developed a nosebleed because the JAK2 platelets are not very good, even though his platelet count was normal. He ended up in the hospital in Tibet for about 2 weeks, where he said he got excellent care, by the way.
Wow.
But where luspatercept is going, as Ruben said, it's an anti-cytokine drug, a different type of anti-cytokine drug than is Ruxolitinib. It might be useful in myelofibrosis per se, as Ruben mentioned, in those who have anemia. It might be good to add to ESAs or instead of ESAs, erythroid-stimulating agents. That remains to be seen. Here you have, and the other question about luspatercept is whether it's going to be used beyond the relatively narrow indication, as Dan mentioned, in the SF3B1 mutant to those with more than 5% ring cerebral, more than 15% ring cerebroblast, or more than 5% ring cerebroblast if they have an SF3B1 mutation. So this trial that you're showing now from the Journal of Press Release, where we seem to get a lot of our information, seems to indicate that luspatercept might have a role in a wider variety of patients with MDS.
So just to finish out on this, Sara, any thoughts or comments about your experience with luspatercept, your experience with patients with low-risk MDS, and any comments about how it affects quality of life? Sara, we could spend a lot of time talking about Sara's research and quality of life in patients, really interesting, but any comments about quality of life as it relates to anemia?
Yes, I think the interesting thing about this study is that it didn't improve quality of life when patients were treated with luspatercept. And so we're trying to understand
that you could measure.
They did do some studies,
right.
actually,
Interesting.
and there was not a significant improvement in their, they used the Euro, I think, EOQ 5D to measure. And so fatigue in the beginning of the treatment really peaks. And so we have to talk patients through that. I have a patient who just started, and we're trying to see what other things could be contributing to his fatigue because it doesn't match up with his hemoglobin. So that's a very perplexing phenomena that's going on with
What's your observation when you use luspatercept and they are having less transfusion requirement? It's one thing to use a scale to try to measure quality of life, but what do you see with the patients?
Well, a couple of patients that I have that have been treated who also have multiple comorbidities, heart disease. One of them, I think, is having arrhythmias, so we're trying to figure that out, but it happened at the same time they started luspatercept, do really struggle with this increased fatigue in the beginning of the treatment. But over time, I try to tell them, just stick with it. We think this, according to the studies, that it gets better with time.
Dan?
Oh, yeah, just following up on that. I mean, I think this is, like everything in our field, and you guys are experts in this, just sort of modifying patient expectations in this with this drug is important. You just heard a dramatic case example, and every patient, of course, thinks that that's going to be them, and we all want that to be our patients. But you look at that New England Journal paper; it was a statistically significant increase in the hemoglobin, but it was like a few points. I mean, so I think just having reasonable expectations for what this drug can do and how long it will last. This is not a forever drug either. So for most patients, it runs its course. So I just think that people really kind of see this drug sometimes as a panacea for their disease, and a lot of patients come in, they've done their own research, and so I think it's just very important to just set expectations with this drug.
I would agree.
That's a great point.
Yeah.
One comment is a guy who's had an interest in this quality of life issue. I think part of the limiter with some of these studies is, again, instruments, I think, like the EQ5D are really not very sensitive for some of the benefit patients like this really receive in terms of the decrease in the hassle of medical care, an increase in oxygen carrying capacity. The EQ5D, many of these things really were validated in the setting of, very severe advanced solid tumor type settings. Where you're really looking for dramatic impact on like activities of daily living. So I really think there is a benefit, and sometimes it's just our tools are not sensitive enough to really kind of quantify them.
No, but I mean, I really applaud. I love it when I see patient-reported outcomes coming out of clinical research. It doesn't, it depends how you do it. Sometimes it doesn't, really give you the picture that you see clinically. But, I'm all in favor of trying to focus more on getting data on quality of life. One final point here, Rich. Here's a paper looking at combining luspatercept and an ESA. Any thoughts about that strategy? Does that make sense to you, Rich?
I think it does. I mean, I think the patients who are ESA candidates with MDS are those, by and large, with EPO levels at baseline less than 500 million international units per ml. If they have ring sideroblasts or an SF3B1 mutation or both, you want to put them on luspatercept. Why not put them on ESA at the same time? Right now, you have to either fail ESA or have a high EPO level at baseline before you can start luspatercept. But why not use both at the beginning? I think this data from Sara's institution is very important, as is the data from the COMMAND study you showed earlier about whether it might have a wider application. So maybe everybody's going to be started on ESAs and luspatercept in the future. Obviously, if you want to enrich for response, you're going to take those with ring sideroblasts and SF3B1 mutations. I think this is very important data, and will probably be incorporated into practice, I would think, soon.
Sara, have you had any patients on this trial?
Yeah, well, I'm not sure if this is retrospective data or looking at our database, but we have used it in combination. And some people who've lost their response, then we add the ESA to it, and then they capture the response.
Interesting.
So.
All right, this is a word about high-risk MDS, and then we'll spend the remainder of our time talking about AML. And Dan, you've really had a leadership role in the treatment of AML in older patients, particularly the combination of venetoclax and hypomethylating agents like azacitidine. But now we're seeing that being used in clinical trial. This is a phase 3 study in high-risk MDS. So this is not AML, this is high-risk MDS. And Dan, it kind of gets into the question of where does MDS end and AML begin? Which it sounds like people are sort of rethinking that. Can you talk a little bit about the vision right now for what actually is AML?
Yeah. So, I think this is, as you said, an active issue in the field. I think biologically we recognize that a 20% threshold to differentiate MDS and AML is completely arbitrary. And, Rich can tell you how it used to be 30% and then changed to 20%. So, I mean, these are man-made, barriers. They don't reflect anything, significant within the nature of the disease. And so, we think that biologically patients with increased blasts, over some threshold, are pretty much all behaving the same and biologically are the same or very similar. And so there are efforts right now to reclassify officially how we think of AML and MDS. And specifically, the thought is that a lower blast threshold at 10% can define sort of this new entity that we would call MDS/AML. And so, I think that is a good effort toward this recognition that the disease doesn't care how many blasts we say it has. The disease is the disease. And so, by that recognition, I think some of the therapies that are very active in AML that we've been working with and excited about and have even been approved could be useful in patients who we used to sort of say had MDS, but really now we would more accurately call MDS/AML. So there's a lot of excitement about that, I think.
So we're going to focus our attention on AML, particularly in older patients. But just one point before we get out of high-risk MDS, Rich, is the question of dosing of venetoclax and MDS. Because one thing I've been hearing from investigators who are looking at this, and actually this strategy is used sometimes outside of indication in the community, and that the message I've gotten from you all is to be careful because you see more cytopenias with venetoclax. What's your experience? We'll talk more about this strategy in AML, but what about HMA venetoclax and high-risk MDS, Rich?
Yeah, so I'll answer your question, and I want to make another point that maybe Sara and Ilene can comment on about what we tell patients. But to answer your question, Neil, at least in the trials that have developed this, in the VIALE-A trial, which Dan was heavily involved with, it was continuous venetoclax dosing, which most of us think is overdosing in terms of temporal exposure. In the MDS trial, the non-randomized trial, there were real problems with some patients, particularly in other countries, who got long exposures to venetoclax. So in this trial, it's only a 14-day exposure. And I would encourage anybody who's giving venetoclax and AZA off-label for what was traditionally called MDS, less than 20% blast, to only use 14 days, not 28 days. But I do want to mention the impact of the changing diagnostic nosology on patient perception of what they have, because patients want to have MDS, not AML. Wouldn't you rather have a syndrome than acute leukemia? I mean, even though, as Dan rightly points out, biologically excess blast MDS and AML are very similar. That's why the international consortium promulgated this category of 10 to 20%, above 10 to 20% blast in the marrow is AML/MDS. So, I mean, I think what we tell patients about just the name of their diagnosis is so important, because if they go if we tell them, oh, you have 11% blast, good news, you have AML, they're going to go to the internet and see that AML is a deadly disease and MDS isn't. So that's a big problem. Not for me as a doctor, because we think biologically, but reality is what it is in the world.
All right, well, let's talk a little bit about AML. We could spend a lot of time talking about it, but we want to highlight a few things, particularly management of older patients, because this has really dramatically changed, and this is being managed in the community. It's a relatively new development. Just about 3 or 4 years ago, when we were first, AML was we were starting to see new therapies coming into AML. And I can remember, I think it was the beginning of 2018, I was doing a program with Rich, and he mentioned the use of venetoclax and HMA, and I said, oh, that sounds kind of encouraging. Are you doing that in your practice? And he goes, yeah. So he was actually starting to do it before it was approved. Then I started to work with Dan that summer, which was right before it was actually approved. And, I guess maybe you can paint a little bit of a picture of where we are before all these studies came in over the last 3 or 4 years, Dan. I mean, older patients often were not even getting treated at that point.
That's right. I think, there were some pretty solid data that the majority of patients in the United States with this disease were not being offered treatment, which was, very discouraging to us. And of course, those conversations to have to sort of have that as your treatment plan when you sit with a patient is really difficult. So this was a huge area of need to have an effective therapy for this population. And by the way, this is the average patient population with AML. It's a disease of older patients. And so, the standard of care that we've developed, that we've had for decades, really didn't fit well with the average patient who gets this disease. So that was a difficulty.
So Ilene, maybe just briefly comment on, sort of the basic approach to AML, where you see a very big difference between younger and older patients, because up until recently, the main therapy had was high-dose chemotherapy, the so-called 7+3 regimen that older patients, 89-year-old patient, is not something you would think about. Ilene, can you talk a little bit first about that path, the intense path, 7+3, other intensive care therapies in younger patients, then allogeneic transplant, and sort of what type of patient, what kind of condition a patient has to be in to take that route?
So, as you said, the younger patient, we don't give them much choice of what do you want to do and how you want to be treated, because they're sick and they're young and we're just starting right off the bat. So right off the bat, they're faced with a 4 to 6 week admission for induction chemotherapy. And then they think, oh, I'm done. And you always have to say you're not done. You're going to be in remission, but the first step to cure is achieving your remission. But how are we going to keep you there? So then we talk about consolidation therapy, and that, depending on your molecular markers and your cytogenetic, what risk category you're going to be in, if we're going to plan on doing a transplant in first remission. So from the moment their life changed with the diagnosis of acute leukemia, we're saying for the next year, this is your course of therapy. So as you can imagine, it's very overwhelming and life-altering for those people.
So, Rich, one comment, we're going to focus our attention on older patients, but also targeted therapy, where we really also seen some really amazing developments. We were talking about HMA venetoclax, but also there's an agent, CC486, so-called oral azacitidine, that is sometimes used in a maintenance setting in these younger patients. Can you talk about that?
Sure. So we basically have two big buckets of therapy for AML. One is your intensive 3 and 7 or FLAG-IDA type of therapy that Eileen mentioned. And at least right now, we're using that in largely younger patients. We also have what we would call HMA or hypomethylating agent-based therapies, of which there are 4 in total: IV or sub-Q azacitidine, IV decitabine, oral decitabine mixed with something called cytisuridine, which is a pill that can be used in MDS. And 4 is the oral azacitidine that you mentioned, Neil, CC486. And the only indication for CC486 right now, or oral azacitidine, is not substituting for its use in MDS or even in older adults with AML with venetoclax at the moment. The only indication for that is in the maintenance setting, based on a trial called the Quasar trial, which was published by Dr. Andrew Way of Melbourne, Australia, in the NEJM, New England Journal of Medicine, a couple of years ago, which was a trial that looked at people who were 55 years or greater, who were candidates for intensive chemotherapy, but not transplant candidates. So that was a sort of a niche therapy. And then they were randomized after they were done with their intensive chemotherapy, which could have been a lot or a little of intensive chemotherapy. They were randomized to oral AZA that Neil mentioned or not. And the ones who got randomized to oral AZA versus placebo live longer. So it is currently approved only in that narrow niche of patients who are getting intensive therapy initially, but not candidates for transplant, which is, in my estimation, a very small group of patients. So I don't use that oral AZA in that approved area at all, and I don't use it outside the label. So I find it interesting, but it remains to be seen if that particular drug will be used beyond that niche indication.
Dan, maybe you comment a little bit, and then we're going to hear about this 89-year-old man in terms of the HMA venetoclax concept, about the possibility in the future of making it all oral. So you have this oral azacitidine agent that, as Rich just mentioned right now, is a very narrow indication, but also he mentioned oral decitabine. Any thoughts about whether or not maybe in the future we're going to be using all oral therapy for these older patients?
I'm very hopeful that will be the case, and what an incredible sort of journey to get to that endpoint where you diagnose someone with AML and then hand them some pills and hopefully say go home and take this, and we have an effective therapy for you. So that's it's an incredible milestone. So I think we're close. I mean, the decitabine, the oral decitabine that Rich mentioned, it is equivalent to IV decitabine in every which way. It is so it could be substituted for IV decitabine, and venetoclax is approved to be given with conventional decitabine. I think there's issues there at the moment with expense and access and things like that. There's also not 100% clarity on whether the oral decitabine might have some interaction with the venetoclax. So I think some of those studies I know those studies are ongoing. Oral azacitidine is a little further behind that point where, that we've been able to declare that decitabine orally is equivalent in every which way. It may be that the oral azacitidine is not equivalent. We don't know yet. There's people working on that. But I think that there is, again, a good chance that we will be, soon in an all-oral upfront era for these patients.
So, Sara, what happened with this 89-year-old man?
He did great. He came in, he was depressed, found out he had AML, and wasn't sure he wanted treatment, but his caregivers were absolutely sure that he needed treatment, and we know how that can go. And so he ended up starting treatment and had a complete response, to the point that his blood counts were so normal that when he broke his leg. He had to have surgery, and he was able to successfully undergo surgery, and he moved back up north. And the last time I saw him, he was still having a beautiful response. But you do have to monitor them very closely. You can't just give them these are your prescriptions, good luck, because they'll die.
Yeah, I mean, we've done hour-long programs just on AML, 2-hour programs. So, we're just giving you a little bit of a tasting menu of some of the key issues for you to be aware of. Just to come back to Ruben, any comments about, we're mentioning that AML and MPNs is difficult to treat, higher-risk patients. Any comments about use in older patients, in particular HMA venetoclax in those patients?
The results so far have been mixed. Many of these drugs intentionally were not tested in patients with MPNs that had progressed to acute leukemia, so the data are less. But there have been both, anecdotal series that are favorable and anecdotal series that have, been less so. The standard still probably remains a JAK inhibitor with a hypomethylating agent, although I think we're still trying to best figure out how to use venetoclax in these patients. I think, as Rich had mentioned, again, issues of length of dose and intensity are certainly relevant. And actually in this group, as I see this mentioned on this slide, we've actually seen some benefit really from, targeted IDH2 inhibition in those with that mutation with Ruxolitinib. So actually I had a patient in San Antonio who had, a very nice 2-year response on one of our MPNRC clinical trials of Rux with targeted therapy with the IDH2 inhibitor. So I'm hopeful that more of the molecular profiling will help us match these therapies up better with these very refractory patients.
Wow, IDH inhibitor plus Ruxolitinib. I've never heard of that one. That sounds like a really good one. All right, let's finish out with just a couple of words about targeted therapy of AML. Again, we've been talking about targeted therapy all week. In a second, I want to hear about Eileen's patient with an IDH2 mutation, 66-year-old man. But Rich, can you kind of paint a picture of the types of targeted therapy that are currently being used in AML?
Well, the big two categories are FLT3 inhibitors and IDH inhibitors that are, at the moment, that's pretty much it for AML, although there's a very important emerging class of drugs called menin inhibitors that will probably be used in both NPM1 mutant and MLL, also called KMT2A, rearranged AML. But the FLT3 inhibitors were the first ones in this group. That's based on the fact that about 30% of patients with AML have an activating mutation in FLT3, which is a so-called gain-of-function mutation. And if you've gained a function through a mutation, it's a little easier to inhibit it than if you're dealing with a loss of function where you're trying to restore a lost function. So FLT3 inhibitors can be used with chemotherapy in the upfront setting, and Gilteritinib is the one FLT3 inhibitor that's approved in the relapse setting. IDH1 and IDH2 mutations are interesting because the IDH enzymes are part of the Krebs cycle, which is involved in energy metabolism. But when you have a mutation in IDH1 or IDH2, it recapitulates a DNA methylation problem that you see with TET2 mutations. Anyway, the IDH1 and IDH2 mutations, which account for 9% and 11% of AML respectively, there's a drug for each one of those. There's ivosidenib for IDH1 and enasidenib for IDH2, and they were both approved in the relapse setting, and eventually one of them, ivosidenib, was approved in the upfront setting as well. So so it's good to have those in our back pocket. Whether the IDH inhibitors will be used in the upfront setting remains to be seen. There have been combination trials, but they are approved in relapsed AML, particularly for older adults. They are a reasonable palliative therapeutic option.
So Eileen, what happened with your 66-year-old man? He had relapsed AML but had an IDH2 mutation. He got enasidenib. What happened?
So he got enasidenib post-transplant after relapse. So he relapsed after his transplant. And we chose this because we thought that was the driving mutation of his relapse. And he got started on this therapy, and his counts normalized. And he had, after, let's say marrow, we did a marrow we did frequent marrows, and he was in a complete remission on enasidenib alone after three cycles. And he had no side effects with this drug. You know, coming on the tails of post-transplant, people are pretty beat up, and you have to be cautious what your therapy, I mean, the worst scenario is you relapse after transplant, so close to the transplant, and you're still beat up from that. You may or may not be on immunosuppressive therapy. So it's very difficult to treat these patients. And as Sara mentioned, the monitoring initially of blood counts and education, I can't stress enough with these oral agents. I think sometimes patients think it's going to be like penicillin, here, take this and you're good to go. And so I always stress the importance. You're taking your pills, you're on your own taking your pills at home, but you still have to be mindful of the side effects and communicate with us so we can work together to give it safely to these patients.
And that certainly is a theme of a lot of novel oral agents that we talked about. One final comment I just want to squeeze in a little bit because it's really interesting, Dan, is the issue of an interesting complication of IDH inhibitors, differentiation syndrome. What is it? How do you diagnose it and treat it?
Yeah, this comes from the unique mechanism of this drug in that it is a targeted therapy. Unlike chemotherapy, we're not sort of just pounding these leukemia cells into submission. These therapies can induce these immature cells to mature or differentiate until they get to what we call a terminal state of maturation, and then they die. And that's a great way to kill a cancer cell, but it can cause complications when you do that sort of with trillions of cancer cells simultaneously, and it can cause a lot of chaos in the body. Back to the cytokines, that's always the right answer. A lot of cytokine-mediated stuff can happen, a very large list of clinical symptoms that can be associated with differentiation syndrome. One really has to be paying careful attention to that. It can be fatal.
But highly treatable.
Yes.
So we're going to finish out our series at 12:15 today talking about prostate cancer. Thanks so much to the faculty. Thank you for coming. Have a great morning.
Thank you.